CV and her list of what she does even now. And then after I'm reading this whole CV, which is incredible, you're still an assistant professor. You're young. You have done more in 5 years, I guess, at UCLA probably. Is that about right? Than I can imagine ever doing in an entire career, and it's really incredible. Fola is from the East Coast initially. She's trained at Yale, she trained at Harvard, she trained at Cambridge. She had a good sort of East Coast, Northeast preppy life, but then we dragged her out to California, and she's one of ours now, but she hangs out at UCLA where she's been for the last 5 years or so. She is an assistant professor still. I'm sure that's going to change very, very shortly, if not already. She has a lot of titles there, including, besides being that, she is the director of quality in their division. She's a health services researcher. She does population preventive health strategies. She works on basically access and healthcare disparities is largely her career interest. She's getting me involved in a project in Northern California, so you're spanning the whole state too, looking at early onset colon cancer and environmental exposures that she's looking at. It's really, she's got an incredible background, and I asked her how much I can say, and she was very humble and said, no, just say kind of nice lady from UCLA coming up to talk to us. So I will do that, and I'll stop and introduce Fola, who's going to talk to us about promoting health equity in GI and beyond. It's our great pleasure. Fola May.
Good morning, everyone. I was promised a simple intro. That was quite, but it's an honor to be here. It's a pleasure to see everyone in person. And the title of my talk is Promoting Health Equity in Gastroenterology and Beyond. We're going to have a little bit of a shift here, but I hope that it can foster an interesting conversation about some of the issues that we've seen with health disparities and health inequities, not only in gastroenterology, but also in our society in the United States. So here are my disclosures. There are many inequities in healthcare delivery and healthcare outcomes throughout the world, but especially here in the United States. In gastroenterology and hepatology, health disparities occur from the esophagus to the rectum and include differences in disease incidence, mortality, but also in management of disease by race and ethnicity. These instances represent the impact of what we call adverse social determinants of health, but they also highlight the numerous opportunities for us to improve health equity for our patient populations. And my hope today is to describe some of the challenges that we currently see in health equity and to discuss what is needed beyond what we're doing currently to reduce disparities. Let's start with a quick primer on the words equity and equality. This infographic provides a visual representation of the concepts of equity and equality. We are all trying to get somewhere. And as you can see in this top panel here, everyone, regardless of their need in this panel, is given the same bicycle to get there. This is the concept of equality, that everyone gets the same supports to reach a goal or destination. On the bottom panel here, everyone is getting the support that they need to get to the final destination. And this is the concept of equity, that everyone deserves to reach that final destination and that final goal, but as in the bicycle analogy, one size does not fit all. In health and healthcare, health equity is the attainment of the highest level of health for all individuals. And health disparities occur when there are health differences that are closely linked with economic, social, or environmental disadvantage. There are countless examples of disparities in health and healthcare in the United States. These disparities, unfortunately, actually start at birth. Neonatal and post-neonatal mortality rates, for example, are highest among Black infants in the United States, as demonstrated in this study that used National Center for Health Statistics data. Compared to white Americans, American Indian, Alaska Natives, Hawaiian Pacific, Pacific Islanders, and Hispanics also have higher infant mortality than white Americans. There are also disturbing disparities in maternal death rates. Data from the National Center of Health Statistics shows that Black women in the United States die at more than double the rate of white women and Hispanic women from pregnancy-related causes. And these disparities also extend to the end of life. This graphic shows deaths per 100,000 people in the US by age group. Black Americans are represented by the burgundy bars and have higher mortality for any age group compared to white Americans who are represented by the blue bars. In other words, Black Americans are more likely to die at early ages when we look at all-cause mortality. And as we have all seen in the last 18 months, differences in outcomes also occur with acute health crises. In the COVID-19 pandemic, for example, we've seen Blacks, Latinos, and indigenous populations die at rates 2 to 4 times higher than white Americans in the United States. The pandemic has actually shown a very bright light on racial and ethnic disparities in this country. And for many of us who work in this field, it's really amplified, I think, for the first time in a while, the importance of our work. So what about our fields? What about gastroenterology and hepatology? And this is a slide I started working on a couple years ago and slowly have just been populating the different disparities that we see in health outcomes that, as I mentioned before, start at the esophagus and go all the way down to the rectum. So for some of these conditions, the disparities are in incidence, so likelihood of getting the disease, or mortality, likelihood of dying for the disease, while in others, so for example, IBD, the differences aren't in your likelihood of getting the disease, but are in disease management, or access to specialty care. But these are all the diseases just within GI and hepatology in which there are profound differences in either incidence, mortality, or management by race and ethnicity. In fact, we've come to learn that the disparities we see in healthcare occur across the entire clinical care continuum. And what does that mean? So the clinical care continuum is the concept that any disease starts with risk factors and ends with clinical outcomes. So whether we are examining risk factors for a specific disease or survivorship from that disease, there are disparities that collectively accumulate into larger differences in clinical outcomes by race and ethnicity. And we actually use this slide and this picture as a framework for a lot of the work that we do in my lab. In our fields of gastroenterology and hepatology, many of the racial and ethnic disparities that we see are in cancers or malignancies. GI cancers represent 18% of the cancers that we see in the United States, with colorectal cancer being the most common. Our field also provides care for 2 of only a handful of cancers in the United States with overall increasing incidence, and that's pancreatic cancer and liver cancer. And in every one of these major GI cancers, we see disparities in incidence and in mortality. Eileen Bowie and our group presented some of our team's results at DDW this year. We used SEER program data from 2014 to 2018 to examine disparities in the relative mortality from 5 major GI cancers by race and ethnicity. In each quadrant here, you can see the rate ratios are risk of mortality for a specific racial or ethnic group compared to white Americans. So in each quadrant, you can look first at the dashed line, which at the number 1, which represents a relative risk of equal to white Americans. And as you can see, mortality is higher than white for many cancers and many racial and ethnic groups. So for example, in the first panel, Latinos or Hispanics have a higher mortality from liver cancer and gastric cancer compared to white Americans, again, as being represented as above that dashed line. Black Americans have a higher mortality from gastric, liver, colorectal, and pancreatic cancer compared to white Americans. And the third panel, looking at Asian Americans, have increased mortality from gastric and liver cancer compared to whites. And in the final quadrant, we can see that American Indian Alaska Natives have increased liver, gastric, and colorectal cancer compared to white Americans. One of my primary research interests, as Dr. Stolman alluded to, is in colorectal cancer, which is one of the most common and deadly cancers in the United States. And as many of us are aware, there are marked disparities in colorectal cancer outcomes by race and ethnicity in the United States. These are data from the National Cancer Registry, and they highlight the higher incidence of colorectal cancer among Blacks in the United States compared to other groups. So Black Americans in this figure are represented by the light teal bars over which there is a red arrow. In fact, Black Americans have a 20% higher incidence of colorectal cancer than white Americans. And also demonstrated here by the gray bars, incidence of colorectal cancer is also higher in American Indian Alaska Natives than in white populations. This pattern is quite similar for mortality when you're looking at colorectal cancer. Blacks have a 40% higher mortality from colorectal cancer than whites in the United States. And deaths are overall highest in Blacks, followed by American Indian Alaska Natives, followed by white Americans, Latinos, and then Asian Americans. In health equity research, more than simply recognizing that these disparities exist, a major goal is to understand why we see these disparities or experience these disparities. Overwhelmingly, the evidence points or supports that these disparities are multifactorial. But rather than biologic or genetic differences between whites and Blacks or whites and Hispanics, we think that the overall differences in health outcomes by race and ethnicity are driven in differences in other factors, like the ones that are shown in this slide, including your family income, the community or neighborhood you live in, your housing, whether or not you are an individual that uses tobacco or alcohol, what your diet is, and how physically active you are. So it's the accumulation of these factors that we think are contributing to the disparities that we're seeing. And we refer to these root causes of disparities by race and ethnicity as differences in social determinants of health. And I like to use this analogy. It's a public health analogy of a river, where what happens upstream in the river is going to impact the currents of the river downstream. So in this analogy, there are upstream, midstream, and downstream determinants or social determinants of health. The upstream determinants are macro social structural influences on health systems and health outcomes. They include government policies and the social, physical, economic, and environmental factors that determine our health. The midstream factors in this analogy are a result of those upstream factors, but they modify or mediate the impact of those upstream factors on the downstream health outcomes. And the downstream health outcomes are what we see in our hospitals and clinics. They are the health-related endpoints that result from the upstream and the midstream factors. They include things like heart disease, most recently COVID-19, and of course, cancers like we've already mentioned today. Systemic or structural racism is an upstream social determinant of health and refers to racial inequities that occur as a product of institutional, historical, cultural, and interpersonal practices within a society that put one social or ethnic group in a better position to succeed while disadvantaging others. We call it systemic because it is ingrained in nearly every aspect of the way people move through society. So it's the policies and practices that institutions like banks, schools, companies, government agencies, law enforcement, and even healthcare are using. And over time, it's these inequities or differences that lead to disparities between groups. I want in the next several slides actually to delve into that a little bit more and to share some examples of systemic racism as an upstream determinant of the disparities we see, not only in health, but in society. And a perfect example comes from right here in Northern California, and this is the concept of redlining. Redlining is the discriminatory practice of purposefully denying mortgage loans to people based on race or where they live. This is a practice that was used historically in the 1920s and 1940s. It is a practice that targeted individuals and people of color who lived in predominantly minority communities. So the US government actually used for quite some time color-coded maps of cities like San Francisco, shown here in this slide, Los Angeles, Chicago, New York, Miami, major urban cities throughout the country to rank neighborhoods as worthy of investment or lending versus not worthy of investment or lending. In this 1930s map here of San Francisco, you can see the labeling of the government-sponsored Homeowners Loan Corporation, and they're labeling neighborhoods as best, which is green, declining, which is yellow, or red, which is hazardous. And these designations actually were highly correlated with the proportion of Black, Japanese, and immigrants living in those areas. And interestingly, if you look online, there are actually government documents that state that these neighborhoods are not worthy of investment because of the people living in those areas. Unfortunately, this has led to no access to loans in these areas and has led to further disinvestments in those communities. Over time, that's led to worse schools, worse shopping environments, food deserts. It's also reinforced racial and class bias in home ownership. And it's crystallized discriminatory lending practices that were only starting to be converted in the 1980s here in the United States. There are long-term impacts of things like redlining and other historical discriminatory practices. And current inequities represent both a result and propagation of that culture that we saw with the redlining. For many Americans, these inequities were not truly recognized until George Floyd last summer and his murder, which led to an uproaring public discourse about racial inequity in the United States. We saw graphs like these that I'm showing you right now, that unemployment among Black Americans has historically been higher than unemployment among white Americans, a gap that only grew during COVID-19. There are also reports about wide ranges in wage income gaps by race. So Black workers in the United States for the same job have historically earned far less than white workers. In 2018, where this data come from, for example, the average Black worker earned just 62% of what the average white worker made for the same job, which is not much better than several years before this in 1967, when Blacks earned 59% of their white counterparts. There are also stark differences in law enforcement. Prevalence of marijuana use, for example, is actually quite similar between whites and Blacks in America. Yet Black Americans are 4 times more likely to become arrested on marijuana possession charges than white Americans. And as highlighted by the civil unrest after the murder of George Floyd, Eric Garner, Breonna Taylor, and others, fatal police shootings in the United States disproportionately kill Black Americans. In fact, Black Americans are 3 times more likely to die from a fatal police shooting than white Americans. So for those of us who've been working in the field of health equity for some time and who have been measuring the impact of race and ethnicity on economic and health outcomes for years, we begin to wonder, is it really race that we're measuring, which is a social construct that is created by society and culture? Or are we really measuring racism when we put it in our models and when we look at the relationship between race and health outcomes? And this distinction is critical, because if we can identify it as racism, then we can identify the mechanisms by which racism is occurring and impacting health and healthcare, and we can design interventions to interrupt these mechanisms. So that's quite a bit about inequities that exist, and I think it sets us up for where I want to go in the next part of the talk, which is how do we actually fix these health disparities? And we'll spend the rest of the time talking about that. So I feel that there are several things that we can do to address inequities in health and healthcare. And I'll spend the rest of my time going through some of the approaches that are listed here on this slide. I hope that I've convinced you of the first bullet here and the first solution, that there are disparities and that these disparities warrant attention, and that all of Americans, especially those who are working in health fields, need to be aware of the racial and ethnic disparities that already exist. This was the goal of the first part of my talk, to highlight these differences that have plagued communities in America since the beginning of this nation. We can take a rather scientific approach once we've made that realization. We can acknowledge the inequities, and then we can identify the mechanisms by which they occur, whether that's by exclusion, bias, disinvestments, or differences in access to care. And then lastly, we can develop and disseminate interventions that break up these mechanisms. And we've learned over time through health services research, through clinical research, through health policy and public health, that the best interventions are multi-level interventions, meaning these are interventions that are going to address inequities and disparities at the patient level, the provider level, the healthcare system level, and the health policy level. Admittedly, we focused a bit more on GI malignancies today in the examples that I provided, but I do want to go back and take a moment to recognize that there are disparities in many other GI conditions as well, including pancreatic conditions and several liver conditions, including hepatitis, hepatitis C, for example, is highest in Black Americans, fatty liver disease, liver transplantation, and also things like inflammatory bowel disease. A second critical action that we need to do to stamp out disparities in the United States is to stamp out implicit and explicit racism in healthcare through implicit bias curriculum development and implementation. And many of you have likely, especially in the last year, received training on bias to help reduce the discrimination and health disparities that we see in our healthcare system. I want to review these topics briefly, and I want to tell why we do these trainings on implicit and explicit bias. Implicit bias refers to the unconscious, unintentional assumptions we make about others due to unconscious associations about different social groups. That's quite different than explicit bias, which refers to the conscious, attentional opinions we form about others, and some use the analogy of explicit bias to frank racism. The implicit bias impacts health and health outcomes in many ways. Implicit bias impacts the clinical decisions we make when we're sitting across from a patient. They also impact our communication patterns. One example that I like to share is there was actually a study that was published 2 years ago that looked at the ways that providers communicate with patients when delivering bad news. And they actually sat observers in a hospital in the northeast of this country, and they made the observation that there was a statistical difference in how we communicate results to patients, whether we're talking to a white patient or a Black patient. And what they saw specifically in this study was that when white providers were providing bad news to white patients, they were statistically more likely to pull up a chair and sit close to the patient to provide this news. When providing similar bad news to Black patients, white providers were more likely to stand at the hospital bedroom door. So these are examples of how implicit bias can even influence how we communicate with patients, which of course we know impacts how they feel about the healthcare system and their likelihood to seek care. Implicit bias then also can result in a poor understanding of health outcomes or disease among patients. It can lead to delays in care. We know that patients are less likely to seek care if they're ethnic and racial minorities because of their hesitancy about the US healthcare system. They might even avoid care in the future. And quite honestly, one of the biggest travesties of the poor communication is the poor role modeling it does for our trainees. So it teaches our residents, our fellows, our medical students that these are appropriate ways to behave in front of patients, which only propagates this culture. And it's the belief that this is how implicit bias through these mechanisms leads to disparities. So our goal here in stamping out implicit bias is to develop interventions and mechanisms to interrupt or to stop this bias. And by doing this, we can reduce disparities. And there are data actually that show that implicit bias trainings do exactly that, and they're quite effective at interrupting these pathways. Addressing bias is important for improving patient care, as we've just discussed, but bias must also be addressed in research and research funding if we are truly to eliminate disparities. Right now, there is a dearth of research in and research funding for health equity, despite the major implications for health disparities on the health of our nation. So we must develop and disseminate effective interventions to address disparities. We discussed a little bit earlier that the steps to doing this are to determine the extent of the disparities, the mechanisms and barriers that lead to these disparities. Then we can develop evidence-based solutions, and we can disseminate and scale those solutions to multiple settings. And effective interventions usually include targeted and culturally tailored interventions for racial and ethnic minorities. They include provider, patient, health system, and policy efforts, as I mentioned earlier. We've had a lot of success with community academic partnerships, and that's actually what a lot of the work that my group does at UCLA Health is partnering with community health organizations and federally qualified health centers to do this work. And also, we've learned that it's very important to engage patients and critical stakeholders in those settings. The challenges in research also extend to clinical trials. Minorities are currently underrepresented in trials. While Blacks are 13% of the US population, for example, they represent only 5% of patients who are enrolled in clinical trial study populations. Addressing this problem has been a major focus of the NIH and other agencies who are putting together mini task organizations and groups to address this problem and to understand why there is a struggle with enrollment, and those challenges occur on the patient side and also on the research side. But without clinical trial data that is relevant to all patient populations, we have not optimized the benefits of science on health. We must also increase representation of underrepresented doctors and researchers to reflect the diversity of the country, and this is another critical solution to mitigating disparities. These data are from the AAMC and from the year 2018 and showed that within gastroenterology, active physicians were 50% white, 23% Asian, 6% Latino, and 4% Black. Native Hawaiian, American Indian, Alaska Natives are represented at less than 1%. The proportion of non-white and non-Asian groups in the physician workflow is far below the proportion that they represent in the US population, and quite frankly, of the patients that we see every day in our clinics. This problem is actually a pipeline problem. And I really found this study interesting. It was published in the JAMA Network Open in 2020. They looked at all internal medicine subspecialties, and those are on the bottom of the graph here. And I'm going to highlight GI, because that's what we're talking about today. And what they're showing is the percent of each underrepresented minority, that's what UIM stands for, compared to their representation in the US population, which is the last box there. So for example, underrepresented minorities are 33% of the US population, but only 12% of gastroenterologists currently working in the field are from underrepresented backgrounds. So we must increase the pipeline of underrepresented minorities into fields like gastroenterology. Representation matters, not just because it offers a diversity of experiences and perspectives, but also because patients who we are oathed to take care of demand it. We know from multiple studies that Black patients, for example, are more likely to see their doctor on a regular basis if their doctor is Black, and follow recommendations when their provider is Black. So these are examples of why a diverse workforce are important for us to better the health of the United States population. The last critical solution that I'll highlight, and again, these are just a few of the critical solutions, is to increase access to high-quality healthcare for all. And I truly feel that gastroenterologists and hepatologists can play an important role here. And they have through philanthropic and service efforts. We've seen examples in our field of individuals that do community service. We've seen work, particularly in New York City, where gastroenterologists and internists have done work in salons and barbershops and churches to increase education about diseases like colorectal cancer and NAFLD. We also have a lot of gastroenterologists in the country who are doing free colonoscopy programs for individuals who cannot receive the procedure on a weekday or during work hours, that they just can't get a day off on a Monday through Friday to get a colonoscopy, so their only option is a Saturday. In particular, there was in popularity for some time this concept of scoping Saturdays, where we would provide free colonoscopies to underrepresented or underserved populations who cannot obtain this procedure by their own means or during weekdays. And then also we've seen examples in gastroenterologists, public health researchers, internists, working closely with community health centers to provide referral services. One of the most humbling things that I learned when I started my lab, and again, our lab is embedded in the Cancer Center at UCLA Health, but a lot of our work emerges from partnerships that we form in East Los Angeles, in South Los Angeles, and in Northeast Los Angeles. And we form partnerships with federally qualified health centers that are looking for assistance to improve their colorectal cancer screening rates. And one of the most humbling things that I learned when I started doing this work with our FQHC partners was that many times they had no gastroenterologist to refer their patients to. So they had patients with chronic gastrointestinal conditions, they had patients with Hep C, they had patients with fatty liver disease, but they had nowhere to send them because there were not local gastroenterologists who were accepting their insurance, or in some cases, the patients didn't feel comfortable leaving that healthcare network to go somewhere else for care. You have to recognize that a federally qualified health center is funded by the US government to provide primary care services, but all they have is primary care. So when it comes to specialty services, they don't have often a direct route for a referral basis. So a lot of the work that we've been doing with our FQHC partners is really to establish connectiveness between them and private practitioners in the Los Angeles area who are willing to work with them, willing to take their positive fit patients and perform that diagnostic colonoscopy, or willing to see general GI patients who have general GI complaints. So I'll wrap up. And I hope that the summary slide is the main takeaways are the things that I hope that you gain from this presentation. First, I hope that this was a helpful example of how health equity strives for the highest level of health for all, recognizing that subgroups require different supports to achieve this goal. Health disparities are very common, and they're the result of adverse social determinants of health, including systemic racism. So it's really easy, I think, in our clinics to look at the most distal and immediate contributor to a health disparity, but we need to be thinking bigger picture to the social constructs that we have constructed here in the United States that have led to these differences in health and health outcomes by race and ethnicity. In order to reduce health disparities, we must acknowledge, understand, and address the role of race and health outcomes. This research must go beyond highlighting disparities to providing evidence-based interventions to address disparities in prevalence, treatment, and outcomes. And diversity allows us to provide the best care for our patients and optimize our science. But achieving workforce diversity in GI will require specific action. And I just want to linger there for a moment, because again, I always like to bring this back to our patients. And we did take an oath to provide the best care that we can for the populations that we are due to serve. And I do think that part of that picture is having a diverse workforce so that patients are more likely to seek care, and also having a diverse scientific workforce so that we investigate all the research questions that can lead to a healthier America. So I thank you very much for your time. I hope that this was helpful. And I'd like to quickly just acknowledge my team and our funding sources for the work that we do. I've also put the website for our lab there in case you're interested in learning a little bit more about our work. Thank you very much.
Questions? Yeah, Gary, please.
Well, fantastic work, super important, a really
you.
compelling talk. I'm not sure how to feel about juxtaposing two of your slides. Mm-hmm. You gave us action points that are within our field that are hugely important, and I endorse them completely. I think back at your earlier slide where you showed all the factors, and healthcare was one icon among so many in society, which really are the sum of this systemic racism that you're talking about. So one question is, have you or others tried to come up with estimates of how much we would move the needle if we, quote, fixed healthcare? How much is all the stuff outside of that? That's question one. And if the stuff outside of that is a big part of it, which I suspect it is, what do you think healthcare providers can and should do that's outside traditional healthcare?
So I think that's an excellent question. Thank you very much for it. And quite honestly, we are so behind in addressing this. There's 400 years of historical events that have led to the situation that we are in today. So in many aspects, you can't go back in time and undo the neighborhood structures and the education structures and system that have led to health literacy differences, differences in education, differences in knowledge about health problems that are contributing to health disparities today. So I think the approach then has to be multi-component in that we can address these upstream factors, and those upstream factors are systemic racism, their education, there are problems with just how we structure neighborhoods in America, while we also address the more downstream or distal factors that are very closely linked to what we do in the health fields. I do certainly feel that a lot of these are the upstream factors that are generated outside of healthcare. I remember when I was doing my PhD, one of the most profound things that I heard Jonathan Felding, who's founded our public health school, say was that the root of all health problems is education. And I remember sitting there in that lecture and thinking, really? Is that where we're going with this? I had just come out of residency. I was like, wow, we're going back in time here. But I think he was right in that the unequal approach to education in this country has led to unequal access to everything from further education down to optimal health. So yes, there are people who are working on the more distal things and looking at education and structural system and social constructs, but I think our role in our field is to be aware of these differences so that we can make sure that we're not propagating the culture in how we provide care for our patients. I'm never gonna ask a gastroenterologist to go fix the education system, right? We hopefully have elected officials who can work on that over time, although it's been slow. But I think sitting across from a patient and recognizing that the barriers that they are facing on an everyday basis are different than the barriers that potentially your white or higher income patient is seeing can have profound impact in your sympathy and empathy for that patient and how you provide care. We've all had that situation where we've been in a room with a patient and they didn't show up for their colonoscopy, and you're just thinking, why the heck didn't you just show up for your colonoscopy? But when you break it down for these patients that have so many competing factors, you start to understand that the barriers that they're seeing in life, the colonoscopy was the least important thing. When you have an elderly mother and 4 children that you're watching, when you're trying to keep 4 jobs, when you already have uncontrolled diabetes, which is your active health problem, what's a screening colonoscopy? What's trying to prevent a disease that I've never even heard of and I don't think I'm gonna get? So I think it's just, in our field, being aware of these social constructs and how we got there, and using that as a tool for providing more empathetic care. I'm sorry, I mean, your question's a great one. I hope that provides some insight.
It does, because I think we struggle with what can we do practically, and do we despair about the broader things, or do we hope that there are forces at play and that maybe there's a shadow effect of what we do, right? If we do things right, maybe there's a spillover effect into some of the deeper things that we're talking about.
And it's the people we're training, right? It is, if we can pass that down to the next generation of gastroenterologists and internists, I think that we can really change how likely patients are to come see us, come back and see us, and come in for our procedures.
Yeah, excellent, thank you.
Hey, Fola, that was a great talk. I'm having just gone through the process with my daughter of applying to medical school. I'm very interested in the pipeline process, and I think of all the advantages she had: 2 parents who were doctors, means to help her prep for the MCAT, and obviously just getting into a good college and all those things. So, in your position at UCLA or with your contacts at the medical school, what's being done? How can we? I mean, it was just striking to me how much money we were able to give her to help her with that process. And if you're struggling financially, it's no way you're going to be able to get that leg up into medical school.
No, thank you for that question. And it's money, but it's also awareness of the system, awareness that these things matter and they set you up for the rest of your life, and quite frankly, the time to do it. We talk a lot about this analogy of a pipeline, and this is in my mind, I'm imagining a long pipe where there's no other entry points except for the beginning and the end. And for a long time, our approach in this country has been to work with elementary age students to try and identify, especially in underserved communities, the bright stars, and to try to lead them through this pipeline to STEM, right? And foster them through elementary school, high school, college, and beyond. And what we're realizing now is that pipeline is so leaky And these students are coming out for many different reasons, many of them social, but some of them just aren't interested in science. They're things that happen over time, that we can't have that approach. We can't start in elementary school and hope that a cohort makes it through to gastroenterology. So I think a lot of the more innovative work that's being done right now is finding different entry points to that pipeline. And at UCLA, I was speaking earlier about the STAR program. This is one example, and it's at the very distal end of this pipeline. It's the concept of capturing people who want a career in science but didn't realize it until very late into their medical training, and then giving them an opportunity to jump back onto the research pipeline. I think similarly, we need to do that at the college level, at the high school level. We need to be identifying individuals who have promise, who have interest, and they need exposure to people who are gonna make them think it's possible. I can't tell you how many times I've been shadowed by an undergrad or a high school student who said, "I've never seen a black doctor. I wasn't even in my kind of realm of possibilities because I never saw anyone who looked like you." So again, this goes back to representation and why representation matters. And unfortunately, all of these things are linked if we really want to further the diversity throughout that range of educational pursuits. I'm excited that your daughter's going to med school. I have 2 minutes and 33 seconds.
I'll make my question fast. Fola, this was fantastic. The way you organized and spoke with energy was inspiring. In liver transplant, we do a lot of outreach and we see different populations, different communities across Northern California for our center. Video visits for us were a way to reach people that couldn't come to us from a geographic standpoint, but it revealed disparities I was surprised I hadn't noticed before. Have you seen research, thought about it, observed what happened during the pandemic with virtual visits and how disparities may have affected that?
Yeah, no, there have actually been a few, thank you for the question, and there actually have been a few publications that have looked at the ability for large health systems to increase their outreach and their patient encapsulation through telemedicine. And I think the pandemic is a perfect example. We were forced into it, right? No, UCLA, for example, I don't think we would have embraced telemedicine in our health center. Our approach really has been to make health centers all up and down the coast and to have people come in person. But the COVID-19 pandemic made us embrace telemedicine. We certainly have several publications now, not just from UCLA, but from health centers around the nation that have shown that in doing so, they've actually enriched the profile of underserved populations who have sought care. And it makes sense because it's easier. I don't know if many of you have spent much time in Westwood on our campus, but driving to Westwood, parking, and walking to the clinic is a whole hour and 30-minute process, okay? And then you've got to pay $45 to park, and then you've got to drive out of Westwood. No one has time for that. And back to what I was saying earlier, a lot of these individuals live in a space and time where they can't take time off on a Monday through Friday, 9 to 5. So this opportunity in telemedicine is incredible for racially or disadvantaged populations, I'll say in general, because it's not just race and ethnicity, it's also low-income populations. The problem now is that we can't get the reimbursement, we can't get the policy to continue it. So there are many of us who are advocating on the Hill to maintain and increase reimbursement for telehealth so that we can continue it. And a lot of the data that they're using on this debate is around its ability to mitigate or address health disparities. So we're hopeful that it's something we can continue in the future. And I think especially for liver, it's gonna be essential. I know our liver center, we're seeing people from Las Vegas, everywhere. They can't, why drive to LA for an afternoon? It's insane, Thank you for that question. I see a lot of comments, but I don't think any questions. And I only have 5 seconds, so. But I'm around and I'm happy to talk to people. And I just want to say thank you very much to the organizers for having me. This is my first time on a plane in a while, so thank you.
Let's use more than 5 seconds to thank you. Really, thank you so much.